John.
Okay, so second thing I want to do is I want to give credit to a colleague and friend, Dan Hyman. Dan is the Chief Safety Officer, and he's also the CMO now at Colorado Children's Hospital. And most of this talk about QI and IRB stuff, you know, I kind of developed for an APA session that we lead. So he gets credit, I get blame. Okay, so on we go. And you guys can see me now?
No, John. Do other people? My screen says paused on your screen. Do people see John?
How about now?
No. There you are.
There I am. Okay. Okay. Good. Okay. Here we go. So yeah. Except now. Okay. So first, we're going to talk about this issue of what's QI science, what's interventional science, and how I sleep at night. Okay. Because what the next two slides are just going to be, these aren't the formal definitions that I use in other talks about QI. It's just kind of what I wrote down coming out of my head, and it's how I section things off. And other people might section things off differently, and I'll stop after I give you these and see if you section them off differently. But look, for me, what's QI? QI is something we do. We use specific principles and methods. It has an underlying science, but QI is the doing it. It's like if we were dentists, dentistry is the doing it every day when there's a person in my chair. QI is the doing it. QI science, to me, is the science underlying the activity of QI. When the dentist is hammering on my teeth, he's doing dentistry, and there's a science of dentistry underlying that, and that's where I put QI science. And then I put QI research as different than QI science. QI research is the generation of new knowledge about some clinical practice or process using QI methods, or research that contributes generally to QI science that's agnostic of the clinical practice or process under study. So let me just stop there. And you know, Peter Margolis might have these structured in his brain a little differently, and Don Goldman have these words structured in his brain, but this is how I do it. What do you all think? And just chime in. I think you can unmute yourselves.
This is Erica. I think it's helpful. I've heard all of those terms in different contexts and never really knew which one was quote unquote right or what it meant. So it's helpful to see that they all have their own definitions and place.
Yeah, according to John. So I'm not trying to get these are right. I just said they help me sleep at night, right? Other people. Okay, so we're going to do just a couple more slides. It's really funny. I can either see you guys or advance the slides, but not both. That's really funny. Okay, so it lines up really with, on the QI and the QI science side, I think pretty well with what Peter did. And I love this diagram too, and the way Peter adapted it, which is that you have QI as the thing we do. There's other kinds of innovation and adaptation that's not QI, because not everything we do that improves something is QI, because QI uses a certain underlying science and a certain set of methods. And then there's QI research on QI, and then there's also research out here that is research that uses quality improvement methods or as part of a quality improvement project. And of course, here's the rest of research, which we made really small because we're biased like everybody else. So then what's implementation science? And you're going to notice a parallelism here because that's how I've structured it in my mind. So implementation, and this is like a dictionary definition, is just the activity of introducing something into actual practice in real world settings. So implementation is the doing it. Implementation science, to me, is the science underlying implementation, drawing from psychology, organizational behavior, anthropology, heavily focused on context, and it's the science of why things actually get uptake. Some things get uptake and some things don't get uptake. That's the science underlying implementation. And I think of something called implementation science research, which is the generation of new knowledge about factors that influence implementation or contribute generally to implementation science. So right, it's the same. That's how I march through these, and that's how I keep them separate in my brain. Who wants to chime in? Good idea, bad idea? What do you know about implementation science? Okay, I'll keep talking for a minute. So implementation science as an NIH thing and kind of being brought into the lingo we use in QI and health services research really has been led by the VA, I think, and Chris can chime in, but that's around 10 or 12 years ago, the VA, where they have a big system, had some real kind of intellectual thought leaders about, we have all these ideas, we're trying to do all this stuff in the VA, some of it gets uptake, some of it doesn't, and they had a bunch of social scientists saying, well, we could study that. It's actually not magic what gets uptake and what doesn't. If you really understood the attributes of your organization better, you'd understand why some things get uptake and some things don't. And we might even be able to help you. And the VA created this pretty sizable cluster of folks, again, largely from social sciences, doing implementation science work and then implementation science research, and there's some great papers out there, and to be honest, I think you all deserve a real session on implementation science with someone who really talks about it for a living, and I think we should get you guys that as part of this seminar. Gina, do we have that on the list yet in the curriculum?
Yeah, we're working on it, and actually there's someone at Penn who Dawn recommended, so we're hoping that she can share with the group.
Yeah. Okay, so good.
John,
Yeah.
Since I would like to ask a question for my own education. So let's say you want to improve a process. So it kind of falls within your quality improvement framework, but you're introducing that something into practice. So it's a new thing. Let's say you introduce a new decision support tool, and you are embedding, quality improvement methods around that introduction, organizing people, monitoring the data, looking at the effects, tinkering with it as you go along. How do you view that? How do you really distinguish improvement from implementation? Because the former, and is it even valid to distinguish the two? Because the former does involve some introduction of a new thing into practice, or is implementation the scaling of it across multiple sites, a la the VA?
No, so I certainly wouldn't distinguish them based on how many sites you have. To me, QI is a certain set of methods for implementing something, right? So you could implement a new thing. Like, look, my institution could buy a new CAT scanner, and we could implement the new CAT scanner, and we could say, okay, the CAT scanner is open, and here's the order set, and we just implemented it. And we're not doing QI, we just implemented something. So we could implement it at small scale or big scale. So I don't think that matters. So to me, QI methods are one way that you can implement something. I think you're getting something that's a little bit harder though for me, which is at some level you have to decide what the it is. So to me, we're in medicine. So let's take the example for medicine. There's the clinically right thing to do. So maybe high-risk patients that meet these criteria need anticoagulation, prophylaxis after surgery. So there are people who study whether they need prophylaxis or not, and what you should use, whether you should use heparin or Lovenox. To me, that's clinical research, right? And then you might So you don't have to do a randomized placebo-controlled trial of Lovenox versus not Lovenox. The clinical thing has been decided. So then you could implement that in your institution or at 10 institutions using quality improvement methods. You're still not doing quality improvement research, in my mind. You would start doing quality improvement research when you start doing research about the quality improvement. So you would say, well, at 5 of these, we're going to use this kind of strategy, and at 5 other places, we're going to use this kind of strategy. And that could be implementation science research as well, especially if you started asking questions like, how does the hierarchical culture in some departments make it slower to implement than other departments which have a flatter organizational culture. So it depends when you're the researcher or you're the leader of the activity, because you might not even be a researcher. What is it that you're doing? Are you just implementing a new thing? Then you're just implementing a new thing. Are you using QI to implement a new thing? Then you're doing QI. Are you studying the QI you're doing? Then you're doing QI research. And are you using kind of the implementation science framework to do research about what promotes and what's a barrier to actually getting it done that pulls from those other literatures?
Yeah, that's very helpful. I just would ask one other question, then I'll be quiet. How do you view implementation differing from research on adoption of innovations?
Oh, I think it's the same. So I think adoption of, right, so we use all these words. I think adoption of innovation, I think it's the same. If what you mean by adoption of innovation, work on who are early adopters and who are later adopters, it's most of the time when we're implementing something, it's an innovation at some level. Do you think they're different, Chris? I'm going to swing that back around to you.
Oh, no, no, I don't. I think they're the same. So I just wanted to flesh that out.
Right.
This is Don, if I can weigh in on this. So it is all the same with a caveat, and that's that implementation scientists, at least as they portray themselves in their literature and at this large D&I meeting, aren't really focused so much on how you develop and test an innovation. They're more, I think, about the know-do gap. Why can't we put evidence-based concepts into practice? They don't really talk a lot about testing innovations, building prototypes, describing the technical specifications or core attributes of an innovation. I'm sure they could do it, but it's not been an area of focus as best as I can tell.
Right, because they're social scientists interested in the questions of what's the underlying anthropology or psychology of the institution that makes it easier or hard. So I agree with all of that. For those of you who don't know us, Don, me, and Chris agreeing on something is a pretty unusual event, and you saw it here today, so it's worth the price of admission. Okay, can we keep going? Let's keep going to this other question, where we're going to talk about QI and human subjects research, and whether your project should require IRB review from an ethical perspective, and whether it does require IRB review, regardless of whether it should require IRB review. And the third goal is to have everyone leave the call able to make a logical argument for why local IRBs should create an alternative pathway for QI projects, which both Dan Hyman and I feel strongly is a better way to do this. Okay, so now I'll talk for a while, but still jump in either by voice or by waving your hands to stop me as I go. So just to bring us back to history a little bit, 1979, these were the top 40 songs. How many are still around? The first Ayatollah was the Man of the Year. it was a different time, and Rubik's Cube had come out for the first time. So, and there was something called the Belmont Report released. And so the Belmont Report is the report that was, the group was kind of convened by Congress. There was a congressional act that ended up in this commission that met at the Belmont estate, and I forget which state that's in. In 1979, they released their report, and the report, just to say it, and we're not going to go back further than this, but really came out of the really evil things that happened in World War II, the Tuskegee experiment, and those were dramatic examples, and many less dramatic examples of what we now see, and they saw at the time, as really unethical treatment of human beings in the service of science, or at least that's what people told themselves. And they came out with these three principles: respect for persons, beneficence, and justice. And you've probably seen some of these along the way. Out of that, once you have a report by a bunch of ethicists, you have to turn that into into kind of federal law and regulation, and OHRP, the Office of Human Research Protection, was born, and 45 CFR Part 46 Part A, which is known as the Common Rule, was born. So who can tell me why it's called the Common Rule? No one. So it's called the Common Rule because they got some large number, and I should know the number, but I don't, of federal agencies to sign on to this one regulation. So the Department of Education and the Department, not the FDA, and the Department of Agriculture and Department of Health and Human Services, and a number of others signed on to one rule, which is really unusual in the federal government. It's actually less usual than Don Goldman, me, and Chris Forrest agreeing on something. So it's really unusual, and they gave it the name, the Common Rule. And the Common Rule has been around for now, like almost, well, it was around for 35 years until it was recently changed, that governed all of our IRBs and what we have to do. Okay. And in the Common Rule, there are a bunch of definitions, and we can talk about how those definitions line up with the structure I gave you. I talked about earlier about QI, but there's definition of research, systematic investigation, including testing and evaluation, designed to develop or contribute to generalizable knowledge, and a human subject is someone living who's identifiable, who's a human subject. What do you think of the definition of research? Who wants to take a swipe at the definition of research, especially as we start thinking about QI?
Seems pretty broad.
Yeah, I agree. It's pretty broad. Useful in making distinctions between QI and research?
I would say the big difference that I'm vice chair of our IRB at Nemours, and that we always focus on, is the contributing to generalizable knowledge, and this idea that QI is not typically designed with the goal of contributing to generalizable knowledge, but instead to improve processes or practices within an institution. I think it's fuzzy, but that's generally what we go by.
Yeah, and I would say that's what most people have done and tried to make that distinction. Look, it's not terrible, right? If you sat me down in a room and said I couldn't leave until I produced the definition of research, I'm not sure I could do better. It's right, but I would say that people overinterpret it and put too much weight on each word, and that's what gets us into trouble, including the government sometimes. So what do I mean? research is a systematic investigation. Well, other things we do are systematic. So I would say QI done well is very systematic, right? There's not research development in QI, but there's development in QI, and there's testing and evaluation. It's not research testing and evaluation, but it's testing and evaluation. And I agree with you. In general, QI, its primary goal is not to develop or contribute to generalizable knowledge, at least in the way we think about it in biomedical science, but it often contributes to knowledge beyond the local setting in which the improvement is targeted, right? And so you're put in this bind. It's like, what if I'm doing really good QI and I'm improving something really well, and it turns out to be really cool, and holy cow, by accident, I could contribute to generalizable knowledge. Like 8 other institutions or 80 other institutions could take what I've done and learn from it, and I might have actually come up with something that's pretty generalizable. And just for doing that, I've just broken federal law. I was just trying to do my own thing, and by accident, we made generalizable knowledge. So it gets it, as long as you just take it as a broad definition, I think it's fine. If you start parsing it, it gets really bad. And when either a federal agency or a local IRB starts parsing it the wrong way, it can get us into silly places. And I think that varies a lot with your IRB, right? Because in a sense, it's based on the intent of the person. It's like, what's in your heart when you started the activity? Is it to generate new knowledge, generalizable knowledge, or is it to improve something locally, right? And there's something fundamentally different about biomedical knowledge. One of the big problems that underlies this whole thing we're talking about today is we take research and QI research and we're putting a framework over it that was really built for biomedical science. So if I do an experiment on liver cells, it's really designed to be generalizable because human liver cells are really pretty similar all across the world, right? So something I find on my local liver cells are likely to be generalizable. If I do something even with patients on a certain kind of, liver disease with alpha-1 antitrypsinase, whatever it is, by its nature, because biology is stable both over time and over place, it's likely to be generalizable. If I learn something about how to set up my trauma center in my emergency department, it is not like a liver cell, and it's not even like a disease. It is highly dependent on the attributes of my setting, the context in which I'm doing it. Doesn't mean that other people couldn't learn from what I do. They'll just have to adapt it. It's not generalizable the way a finding on a liver cell is, but it is, it's generalizable in another way. It's generalizable with adaptation. And it's still, I think, sometimes quality improvement and not research. Yeah, I'm not going to spend a lot of time. You all know there are different kinds of research, and just because something is deemed research and should have oversight by an IRB doesn't mean it requires consent. Depending on the attributes of the project, IRBs have latitude and pathways to do different things with consent and things like that. But we're talking about whether it really even needs IRB review at all, because how could I make the bold statement that some things just don't require oversight by an IRB? And fundamentally, it's the statement that's also in federal regulation that it says that routine healthcare operations do not require oversight as human subjects research, right? Just think about that for a minute. We see patients, we operate on them, we provide care, we do all sorts of things, and it doesn't have oversight by an IRB. And quality improvement, and remember, going back to my first slides, just the activity of quality improvement, making things better, using rapid cycle tests of change, is part healthcare operations that doesn't require oversight by an IRB. And here is, as against my my definitions that help me sleep at night. This is a definition from the Hastings Center that's sometimes used: systematic data guided activities to bring about immediate improvements in particular settings. And I would say not primarily intended for application beyond the unit, but certainly do have learning that's adaptable to other places, and especially with multi-institutional QI, it gets very close, or even goes over the border of being generalizable in some way. Well, let me stop there for a second. Questions, thoughts, challenges? Okay, I haven't said anything controversial yet. I'll work on it. When we talk about QI related research, it is different. The potential harms than some other kinds of biomedical research, at least on average, right? So most QI related research doesn't have the magnitude of risk that other, that testing a new chemotherapeutic agent has, let's just say. It's just not that kind of research. The intervention's often at the system level, not the individual patient, although we'll get to that. The interventions, and when I say the interventions, I mean the actual medicine given or cognitive therapy given, is generally something that could be just implemented tomorrow because it's within the standard of care in the profession, right? If you didn't have a QI process, you could say, look, tomorrow we read a paper, we read up to date, or we looked at a new AAP guideline, and we're implementing X, and nobody, in our emergency department or our ICU, and it's just something you could do. And so it's kind of funny that implementation of that thing, if you do it in a structured way and try to learn from it, is suddenly research, when you could have just done it by edict next Tuesday and no one would have suggested it needed IRB review. And often in QI research, we're studying meta issues. It's true of implementation science research as well, kind of implementation fidelity, variation by context compared to the direct biological and clinical effects. So it's kind of, at what level are you, what's your research question? Does the thing work? Does the biologically or psychologically active thing work? If that's your question, that's absolutely oversight by the IRB. If it's, does this way of letting people know about this practice, or having them remember to do this new practice, if in one unit we put signs up in the bathroom to remind people, in another unit we put a checklist at the bedside, is research on which of those is more effective? So that could be research too. That could be answering some generalizable question about human behavior. But you know what? We're still not doing the research on the start Lovenox in high-risk patients, right? We're doing research about whether bathroom doors or checklists by bedsides are better. It's a different kind of research. And to be honest, those things, I could have done either of those things without asking anybody either. Nobody, if I wasn't doing research about it, no one would suggest if I want to put checklists up at the bedside in Melissa's ICU next week, that I have to go to the IRB to do that if we decide that that's a good thing to do. Okay, so we get this, when does learning from data, what we do in QI, what we do in learning health system, become this seeking generalizable knowledge? When does measurement, because QI is all about measurement, becomes systematic collection? And how do we think about routine operations if we really want to have learning health systems, which this whole K-12 is in some ways about? So this is an example from Dan Hyman. 35% of the time patients were discharged with a written asthma treatment plan. a team came together, PDSA cycles were run to test different strategies for improvement. How many people think that's research? What they were doing is research so far, the first 3 bullets. Anyone? Okay, how many people think they're doing QI? Not everybody nod. It'll be fun if everybody nod. Oh, that's good. I like the hands. Right, so that's QI. Now read the 4th bullet. The team was going to present their work at national meetings. Does that change whether it needs to go to the IRB? Raise your hand if you think that changes whether it has to go to the IRB. Wow, I didn't get anybody. That does not change whether it has to go to the IRB. We don't punish people who have learned something from local experience by sharing their work with other people. That's just crazy. But there are still IRBs out there that believe that wanting to present your data either in written form or in a conference makes it, shows that the intent was generalizable knowledge, and it makes it research, and that's crazy. And I'll come back to how I can assert that's crazy, and how even OHRP, the federal agency, has been really clear that that is not sufficient to make something research or make it a search for generalizable knowledge. Okay.
John, can I ask you a question?
Yeah, please.
In your prior slide, if the team wanted to use randomization or a step wedge approach rather than PDSA, does that change your evaluation? And then the second question is, what if they want to publish a paper so that they can share that with a broader audience because they think it's potentially generalizable? Does that change your assessment?
Right. So let's ask the group. Right. So first of all, we're not testing whether an asthma treatment plan is effective or not here. Right. We've decided that the Joint Commission requires everybody to have an asthma treatment plan, and we might test in a stepped wedge. Everyone know what a stepped wedge design is? Nod if you know what a stepped wedge design is. A stepped wedge design, so some people don't. So a stepped wedge design is, in a way, a variation on cluster randomization. So let's say I have 10 units in the hospital. I'm not going to randomize by person. Well, one way to do it would be randomized by person. That's hard to do because there's too much contamination between people once all the nurses know what a asthma action plan looks like. And so I'm going to randomize by ward. That would be a cluster randomization. I have 5 wards that do something and 5 wards that do something else. And then stepped wedge means in the end, I want all the wards to get it. And so I'm going to do it first on 2 wards, and then I'm going to keep those going and do another 2 wards, and then I'm going to do another 2 wards, and ultimately I'm going to do all 10. But in the meantime, I'm going to have comparators, the ones who haven't done it yet. So you get what the stepped wedge looks like. And again, it's a more rigorous from an inference perspective of whether my intervention worked. From a scientific inference perspective, it's more powerful. It's more powerful than just certainly a before-after design, and even probably more powerful from an inference perspective than doing PDSAs all at once in all the units, right? So Chris asked the question, we do something with a more scientific design to implement something that's required by the Joint Commission. Does that make it research that needs IRB? How many people think that kind of cluster randomization, whether or not it's stepped wedge, but I'm going to do it on half the wards and not do it on the other half, does that make it research? How many people think it makes it research?
I would certainly be more concerned. I mean, I think it takes a closer look, or requires a closer look for sure.
Okay, so it takes you closer to the line. I agree with that, right? All this stuff is kind of on a continuum, and that brings you a little closer to the line. Yeah, Chuck?
Yeah, I was just thinking, like, what if instead of calling this a step wedge or randomization, you called it a PDSA to see
you know, what happened if you did it this, do you know what I mean? Like, is the language here changing a little bit how we're supposed to think about this? Even if practically it's like, oh, let's just try it on these wards to see what happens first. Is it because you're collecting the data where you weren't doing it that makes it research? Does that make sense?
Yeah, I think that's a really good, I think that's a really good question to me. And so these are the ones, we'll get to some more examples, where it does become a little bit of a judgment call. Because once, and so here's an example that I would call research. A fellow is really interested in asthma care, and he's in the next year going to do an intervention on five inpatient units and not do it on 5 inpatient units. And at the end of that, there is no plan to implement what he or she found across the hospital. To me, that's health services research. Don and I have been, and Chris have been teaching health services research for many years. That's health services research. What makes it quality improvement is there's a strategy and a goal of this hospital to get in line with the Joint Commission requirement. That's the end goal. And they're trying to learn something along the way. And a step wedge design might be a way to help them learn along the way what's most effective and what isn't, with a little more precision than another design. So it is, to me, an example that's a little bit, it's on the line, and it depends how you want to frame it. And at the end, I'll show you how we frame it at Boston Children's to help make that decision. So I want to be clear. I think there are times when cluster randomization can absolutely be used, and an activity can still be quality improvement and not require IRB oversight. I believe there are those examples. But like you all, I believe that cluster randomization brings it closer to the line, and we're going to have to think about it in all its attributes to make that judgment. And I'm also going to say one of the other punchlines we'll have towards the end of the talk is, I don't think the activity leader, I didn't say the investigator because I haven't decided if it's research or not yet, the activity leader shouldn't be the one to decide that on their own, because it's a hard decision. The minute we say something is closer to the line and requires judgment, it puts someone in a kind of conflicted position to decide that on their own. And then let's take it one level down. Let's say we have something like this. We're going to do a randomized trial of putting a reminder in some unique way. We're going to actually tattoo the reminder to the forehead of the patient. It's not going to last long. It's going to be one of those 3-month tattoos, okay? And we're going to do individual randomization. And the question for you all is, do you think you can randomize at the level we said that maybe sometimes you can do cluster randomization, randomize at the level of the clinic or the ward? Do you think you can do individual randomization and still call something QI? How many people think you can? How many people think individual randomization makes it research? 2, 3, 4, and a couple, oh, 5, okay. So you guys think it makes it research. I will say I lean towards it makes it research. So people fight about this. And like, these are ethicists and stuff. So the fights are actually really vicious because they're ethicists, just kidding. I think it's very hard for me to come up with examples with individual randomization that I don't think should have IRB oversight. And the people who push back, they say, but if the thing you're randomizing are like, something that you could do tomorrow anyway, like if you randomize which soap you put in the soap dispensers, people don't know which soap goes in the soap dispensers. They don't care which. So why would individually randomizing make that research instead of why? So I can come up with examples, and maybe that's one of them, changing the soap in the soap dispenser in the patient rooms, where you could convince me that it's part of a QI activity. But most things, I think individual randomization gets over the line. And I say that mostly because I think people who are randomized want to know that they're randomized. And they just want to know that fact, that they're part of a study. And I think we have a history of almost a century of people getting really pissed off that they weren't told that they were randomized. And you say, well, don't they want to be told that they're cluster randomized? And I say, yeah, maybe, but that's a little different. To me, if I got admitted to one ward and this is the way this ward does things, it feels less personal than if you flipped a coin about me and I ended up heads or tails. But we don't have to settle that. I would just say randomization at the patient level is people disagree about. Don, do you have a strongly held view about randomization?
Part of me says that cluster randomization is a way of hiding something from the patient because it's kind of washed out in this vague concept of the ward or whatever. And in reality, I think the issue is exactly the same. If you are randomizing patient or ward, the issue really is, are you trying to get care closer to the established standard, or is there something more than minimal risk? I do think that the argument is kind of obfuscating the core issue. And I agree with you that patients in general want to know what's going on. So maybe this is an area for assent rather than consent. So you're going to come onto the ward. We're going to be doing all kinds of things to make sure you're getting the best possible care according to evidence. And it's NYU Langone just had that study in the New England Journal as their experience in using factorial design electronic studies to determine what worked and what didn't, and nobody was asking any questions about that. So anyway, it's a complex issue. The one thing I can't remember who made the comment about why don't you just call step wedge a PDSA. I have to intervene there and just remind us that when we talk about PDSA, at least in improvement science, these are not run a step for 3 months or 2 months and see what happens. These are rapid cycle, small tests of change to see whether or not your implementation thinking is going to work out in practice. And it's not meant to be something like a step wedge trial, although I've seen many improvers spend 3 months planning, 3 months implementing, and then concluding rather than doing tests about their prediction.
Fair enough. Jeannie, I just want to time check. So we're doing this seminar until what, 4:30 p.m. or so Eastern time? No. Do we go to 1:30? Is that where we're headed?
Yeah, we have, I think, technically till 1:30. Okay,
and we'll try not to take. You'll get tired of listening to this before then. So look, this is part of trying to inform what's clearly research, and this I took, and you'll see here in the slides, but Jeannie sent it out. OHRP, and we'll talk. They couldn't get sensical revisions to the common rule in the most recent revision of the common rule about QI because they couldn't get everybody to agree on language. But they have a set of frequently asked questions that are really helpful and really, I think, make sense and say what they mean in the regulations. And here's one of them. That, look, if something's really introduces an untested clinical intervention, not the implementation intervention, but a clinical intervention that include not only improving quality, but also creating new information about patient outcomes about the intervention. That's research. And then we can quibble about what's a clinical intervention versus a behavioral intervention. But let's keep going. I'm not going to spend a lot of time on this issue, although we should probably, as a group, come back to this issue at some point. What happens when we do QI collaboratives and other multi-site initiatives where everybody's doing QI and trying to improve care locally, but you're engaging multiple delivery systems, which increases the risk of accidentally coming up with generalizable knowledge, right? And crossing that line, which is, right, even talking about it that way is crazy. And it also has a transfer of identifiable or some information. And does that change the requirement for IRB review? So the first thing to say is, we could talk a long time about whether the existence of HIPAA really makes it kind of, if the only risk is about transfer of identifiable or non-identifiable information, that's covered under HIPAA. So do we really need the IRB to weigh in if that's the only thing going on here? And I'll tell you a little story, but I'm going to tell it really quickly. I'm going to buzz through it because it's just the lesson. So Peter Pronovost, who was at Hopkins for a long time and a real leader in pediatric safety, particularly in the ICU, did these large-scale implementation studies to decrease central line-associated bloodstream infection in 103 ICUs. He was at Hopkins, and he got the Michigan Health and Hospital Association to do this. He had funding from ARC as research. There was no randomization. It was a pre-post design. They had data on catheter days and collapses that were aggregated to the ICU level. No individual patient data was shared, and it was highly successful, right? So that's great. And he ran it by the Hopkins IRB, and they said it was exempt. And somebody dropped a dime, and they said it should not have been exempt. That what was being done was research, because he was funded to do research. And if it's research, every single site, every one of the 103 sites needed to have IRB approval to be part of it, and patients should have had informed consent. And OHRP found that the IRB had screwed up, and that there were subjects who were both providers and patients, and that the consent issue should have been addressed. So what do people think? This was, I think, about 2004.
Scares me.
Who said that? Melissa said it. Yeah.
Yeah. I mean, I think you're informed to have, you try to run it through a system and get their feedback on it, and then people either change their mind, or it's a different part of the elephant that you're looking at, and there's a different decision point, and now you can't move what you found forward. And ultimately, and so it's just, how could you avoid, immediately I'm jumping to how could you avoid this sort of situation? What could you, what's the oversight when you already went to the oversight to begin with? So
you're focused on, look, you're the investigator, you did the right thing. You went to your IRB. I think no one said Peter did the wrong thing. He went to his IRB. They made a determination. It's the IRB that's in trouble here more than Peter, right? So yes, it makes our blood pressure go up. It's also just crazy on its face. It means you could never do this. I mean, the state of Michigan got 103 hospitals to try to decrease central line associated bloodstream infections using evidence-based practices, not testing some new drug they were going to put in the IV fluids of every patient, not testing a new catheter, just trying to get people to do the right thing. And here the feds are saying, no, you can't do that. You have to go through 103 IRBs, which we all know you could never get something through 103 IRBs. In a lifetime, you couldn't get something through 103 IRBs. Okay, so I'm going to tell you the rest of the story so Melissa's blood pressure can come down. So they talked a lot about OHRP said, no, this was research, you guys screwed up. And then a few years later, Pronovost was going to do another study to expand CLABSI to multiple hospital systems. And he said, he wrote to OHRP and he said, look, just tell me what you want to do. Just tell me what you want to do here, and don't come back and find me deficient later. Let's just have a conversation up front. And that was a few years later, like 4 or 5 years later, and OHRP had come around by then. And OHRP determined that in some studies, if it was implementing a current evidence-based standard of care practice at each hospital site, the activity was not research. In each one of the hospitals, it was quality improvement. They were just trying to improve their central line bloodstream infection prevention. The analysis of data at Hopkins was research. Pronovost was doing research, but the sites weren't. And they also, so it did require, it could require, you could argue, some oversight. But in this case, since it was not identifiable information and no interaction with participants, it was not human subjects research by the definition we put up earlier. So it's funny, in 5 years, they actually, partly because of the controversy that ensued over their first finding, they kind of came around. And between this and the evolution in actually the requirement by NIH and others to have central IRBs, or at least reliance on a single IRB for multi-center studies, we've kind of gotten past that relatively quickly. And so you can look this up, and it's all public. But I think it was an instructive episode. I'm gonna. We've talked a lot about this. You know, we could come up with a list about what makes something a single site project. What are the questions we should ask if we're going to ask questions? Does it have to go to the IRB? And here are some of them, I think. Do the interventions promote standard care or established care, or some new, either biologically active or innovative, something that's different, or are they promoting standard care? We'll get to this one in a minute in a little more depth. It's really important to me whether the project furthers the goal of the clinical leadership in terms of their quality strategy. That is, and I use the example of a fellows project. If the goal of this is that, you know, a resident needs a project and wants to have an abstracted PAS and contribute to new knowledge, I'm not dissing that. That's great, but that is usually not quality improvement. That's not how quality improvement happens. Quality improvement happens by the leadership and the clinicians, and I don't just mean leadership, because it can be the nurses and it can be the patients, coming up with what are the problems in our local healthcare delivery system, in our hospital, on our ward. What are we going to do to solve them? And then we do a project to solve them. And so it really matters to me whether this just comes from someone who's looking for a project, in which case it has high likelihood of not being sustained, or whether it's coming as part of a strategy, and this is what we have to do next to understand the strategy. Patient risk, data collection burdens, and data collection burdens, we ask the question, is it consistent with what's expected in routine care and organizational improvement? What do I mean by that? I did years ago, this is right, the simplest QI project. I wanted to improve. I worked in a primary care clinic, written discharge instructions from patients seen on the urgent care side, right? No one's gonna argue with me, I think, that it might be good to write down some of the recommendations for when a patient leaves the clinic, but we weren't doing that very often because it's busy and we talk to patients and we think they understand us. And so we picked a sample of 20. So we did all these interventions. We put signs up. We educated people. We tried to make it easier to have discharge instructions. And each week we randomly selected 20 patients, and we called them and we asked them 4 questions. It's like, it was like, did the clinician give you instructions verbally about what to do with your child? Did they give them to you in writing, in a language you could understand? Did you have questions that weren't answered? And, you know, how did your kid do? And rate your care on a 5-point scale, right? It was something like that. And I would say that level of questioning is consistent with what Starbucks asks you about your skim oat milk latte, a pumpkin spice thingy. It's what Marriott Hotels asks you, and it's what healthcare organizations, it's right in line with what they ask you. If I had all sorts of other questions, like I wonder, I really want to really answer the question how parental education level, how parental affects whether they, and so I'm going to do, in addition to my 5 questions, a battery of intelligence testing. And I also want to know if they're depressed, so I'm going to do a depression screener, and I'm going to do so, right? And suddenly I have a 25-minute interview, which that's fine, but that's not the kind of respondent burden that's generally consistent with QI. That's the respondent burden that we do when we do research. Are there other questions that people would want to add to this list as you think about it?
I just think the question about, oh, sorry, go ahead.
No, go ahead, Melissa.
This is Erica. I think the question about whether the project furthers the goals of the clinical leadership and team is really interesting and important. I have found that some graduate programs are now in various fields, like in this case it was nursing, are requiring that their students do a QI project as part of their degree, not a research project. And I think it's really tricky because then it puts a clinical unit in a position where a student's coming in and saying, I need to do this project. And is it QI? Is it research? It just, I don't know. I think that's very interesting, and I'm just curious as to how other places handle that.
So I agree, and it's not just that, right? So all of the certifying bodies that come in and review our residency programs and every fellowship program for the board are saying everybody has to do a QI project. So we have this actual need on the training side for everybody to do a QI project. And how do we make that align with something that's really quality improvement in a program or in a setting, right? I think the answer to that is I'm less a fan of each person coming up with their own project and more a fan of having the system say, wait, this is a real resource, the fact that we have graduate students, in our thing. And so what's our quality strategy for the next 3 years? And then how could we use this resource we have in a way that's good for them and meets their requirement and furthers our quality strategy. It's a little sometimes easier said than done. I'm going to skip a lot. We talked about comparison groups and randomization and some of the issues there. I'm going to skip this next part because it's less dramatic because we now know the answer. So I'll just go through it really quickly. So in 2015, there was a notice of proposed rulemaking by HHS, Health and Human Services, and 15 federal agencies saying they wanted to adapt the common rule. And the reasons for doing that were because of genetic studies, multi-center studies, and they also knew that this issue of what's QI and what's research should be dealt with as well. And there were multiple iterations and things published in the Federal Register and comments by lots of people. And you can read these slides. And the bottom line is a new common rule was published and is now implemented, and they couldn't figure out the QI stuff. They couldn't figure out language that made any sense at all to do what we're trying to do today, which is to draw this kind of line, even a fuzzy line between research and quality improvement that doesn't need research oversight. And they left us right where we were back before this thing, and they published it anyway because the bottom line is that wasn't the biggest problem they were trying to solve. They were really trying to solve the problem of how do we do consent for leftover specimens where we're going to get do genetic testing later for studies we haven't even thought of. How are we going to mandate single IRBs? And they just didn't care enough about trying to find a way to craft this border between QI and research. So they just punted. They really did. And so what we have, and there are some links in here that you can go to, but the frequently asked questions kind of give us an idea of what they meant, but they just couldn't get to regulatory language. So we're back where we started. Yeah, and look, here are the things that are really clear. That OHRP thinks there is a thing called QI, that it does not constitute human subjects research, that it doesn't need oversight by the IRB. They left the research definition the same, and they reiterate that minimal risk, even if it is research, can receive expedited review, and that they reiterated that just intending to publish something is not a sole criterion for something being research. I have to tell you, in working with people and reviewing things that are going in and submitting journal articles, if you're going to say something is a QI project and it's done as a QI project and it's done without IRB oversight, and then you go to publish it, you better not have the third paragraph of your introduction say, therefore we undertook a research study to determine X, Y, or Z. If it's a QI study, you got to say, we're submitting it to the quality pages of pediatrics, and let us tell you about the methods we use, which are quality improvement methods, and why we did this as a quality improvement project primarily to improve care locally, right? So you're kind of making a decision about how, not whether you can publish it, but how you can publish it, and to some extent where you can publish it. I'm gonna skip this. This is these are different examples, but what I really want to do is get to. We can come back to the examples if we have time, but what some organizations are doing. So Colorado, where Dan is, has a committee called ORCORP. Dan loves the acronym ORCORP, but they've set up a separate committee to review things, and it has some members of their IRB, but also other people not from the IRB to bless things that might be important for the institution to have visibility into and oversight of, but nobody believes constitutes research. And then in this you'll see their framing of the characteristics of research, QI, and program evaluation, which I think is a good one. I'll tell you what we do here, and this was something we started in the Department of Pediatrics, and it's still not perfect here across the organization, but I think it gives you the idea of kind of how you would implement an alternate approval process. So what we do in pediatrics, and Don and I both sit on this committee, is if a project leader has an activity that they think really doesn't constitute research, and they don't think it needs IRB oversight, instead of just sitting in their office and making that determination themselves, they can fill out a really quick application and send it into us in the department. And the committee that looks at this is the quality department of the Department of Pediatrics. Sorry, the quality committee of the Department of Pediatrics. The chair of the department sits on it. The vice chair for quality sits on it. A number of us from the institution who have expertise in quality improvement sit on it. So in 2 pages, tell us about your project. It's advisory. It doesn't, there's no federal agency, but, and then we ask people to fill out this table. And we ask them to not just give us yes or no, but explain it. You can see the questions. Is it primarily designed to improve care locally? Is it primarily designed to create generalizable knowledge? So that's different than could it possibly create generalizable knowledge, but is the primary intent generalizable knowledge? Are personnel who provide the care involved, and then do they view it as desirable? So is it coming from the outside onto this ward, or is it part of the ward? Does it use any experimental medications or devices that anyone in your field would consider experimental? Does it test a specific scientific hypothesis about biology or human behavior? Does it use kind of multiple cycles of change? Is there randomization at the patient level? Is there randomization at another level? None of these are by themselves determinative, right? But that's what we want to know so we can wrestle with it. Does it receive any research funding? Is data collection commensurate with that commonly used in QI? Will data be transferred outside of Boston Children's Hospital? And are there any risks to subjects beyond loss of privacy? And so those of us who sit on this committee look at these applications, and it doesn't take long, and we weigh some of these things, and some of them are slam dunk, and some of them, the easy ones, are the ones where we say, oh, that sounds like research. You got to go to the IRB. And then some of them are clearly quality improvement, and some of them we wrestle with, right? But that's how we've kind of brought these questions outside of the IRB. And I want your feedback on those in a second, but I want to show you something that I think is really important. We have two letters we send out, and one is the letter that says, thanks for submitting this. This really smells like research. We think you should go to the IRB, right? That's a quick letter. The other letter is longer. It sometimes has some comments about the project in particular, but it has this paragraph that's really important to me because I wrote it. But it says, if you move forward with this is QI, it doesn't fall under the authority of the IRB, but the clinical leaders, the division or program in which this is being undertaken continues to have responsibility for all aspects of the project, just like they have responsibility for all aspects of the clinical care that happens, right? So I can't go, it's not that this activity doesn't have oversight. Of course it has oversight. When I practice in clinic, I can't just stick needles into children because I have had a bad day. The clinic director and the chief of the division and the department chair above that are responsible that we're providing care and that I'm providing care in an ethical way that meets all the standards. And if this is going to be QI, those same people have to take responsibility for it and oversight of it. It's not a free-for-all. So I'm going to stop there. What do people think about the things we came up with? Do you think we're missing something? And other places have come up with things like this, and we stole some of this from other places. So I'm not presenting this as no one else has done this. But what do people think of this as an outside of the IRB process? And do you think that's a good idea or a bad idea?
Hi, it's Theta.
Yeah.
So I actually really like the process and the oversight, and I haven't seen this before in a way that continues to give clinical oversight and some responsibility to the stakeholders that are involved. But I was also wondering, with regards to when this goes to the IRB, is there a second letter that goes to the IRB side? In that, do you get feedback from the IRB that thanks for sending this to us, this is how we ended up deciding on this project, or no, it's still QI? Despite having gone through all that.
Yeah, so I will say through back channels, we have a really great director of research compliance in our IRB who's been doing this for 30 years here with Don and with me. And we have a lot of back channel communication about things that have come to them as research that he's like, John, will you look at this? Because this looks more like QI. And then things that we look at that came in as QI and that we're sending over to them. Look, in the end, individual project leaders have a responsibility. They're the ones that are going to get in trouble if they start doing something that's really research without IRB approval and without the appropriate informed consent. So we're trying to be helpful to them, and I think it works really well. But you're right. I just want to give a little airtime to the alternative. The alternative of some institutions is they just say the IRB should look. There are two ways to go here. wants to say the IRB should make all these decisions, that we should get people knowledgeable about QI onto the IRB, and everything should come into one place, and they should decide what's research and what's QI. And if it's QI, they should send a letter back saying, you don't have to bother with us again because we think this is QI. It should all be housed in the IRB. We and Colorado have taken the other tack, which is let's set up a committee outside the IRB, because it's really hard, I think, for IRB members who are really deeply focused in that kind of informed consent and research paradigm to get out of it and say, really, is that research at all, or is that just part of hospital operations? Did I answer your question? Yeah. Others?
I have a
John, this is Melissa.
Go ahead.
Stephanie, why don't we start with you, and then we'll go to Melissa.
Yeah, this is Stephanie from Colorado. I had a quick question about using sort of what's truly considered standard of care. So we've been involved in a multi-site QI improvement project for opioid-exposed newborns in the state of Colorado, and are using a new tool that's been published in other QI frameworks but hasn't been validated. And interestingly, have gotten some feedback that might not be appropriate because it's not, to some people, isn't considered standard of care yet. And I'm just curious what your take on that is when it's been used in other settings but hasn't necessarily been a validated sort of technique or approach.
Right. So so I would say these are all the edge cases, right? These are all the things that are hard, right? Because if you so I'll go back to a couple things, and I don't even think I'm going to give you my opinion because I haven't seen the thing. So I'm going to punt too. But go back to the thing. Even though, first of all, can I just step back and say the evidence base for what we do in pediatrics is lousy. And that's despite the fact that Chris Forrest has been trying to build that evidence base for like 40 years, and it's still really, really terrible. And so lots of things are not well validated and have been tried different places and have been spread by folklore and end up in AAP guidelines because it's the best we got, and are all things that you could implement in your hospital without study or without quality improvement methods. You could just say next Tuesday, we're just going to do it this way. And nobody would say, but there hasn't been 3 randomized trials on it, and there hasn't been a meta-analysis. You would say, whatever, that's most of pediatrics, right? Mm-hmm. And so there's a way in which now, because you're doing this thing, people are using a higher standard, and that's a little crazy. On the other hand, because this thing doesn't have a lot of evidence behind it, and I don't know what the thing is, but in the process of doing this, one might have the ulterior motive of actually doing scientific research to prove that this thing is worthwhile. And I think we have to be careful of not doing clinical studies under the guise of QI because then that does bleed over into something that might need to have research oversight. So I just think it's a great example of the fuzziness of this.
Yeah.
Melissa?
My question pertains to how multi-institutional registries, like the Pediatric Cardiac Critical Care Collaborative, for example, impact the definition of quality improvement. So if we're doing this all at our local level, but we're collaborating together with a common goal, how does that impact the definition?
So that's a really good question, and I think people have grappled with this in different ways. So some of the registries have just said, and I think the early registries especially, look, we're doing this registry, we're pooling our data because we want to improve care for our patients, and the main goal is quality improvement. And you could imagine with HIPAA protections and that as your major goal, that that you wouldn't need IRB oversight. But a lot of them said, but we're also going to use this as an engine for research. And so we're going to get to cover ourselves because we don't know where this is headed, really. We're just going to get everyone to sign a consent form, a research consent form that's really broad. And no matter what we decide to do later, we'll be covered in some way. So I think there are two ways to go. One is that, and we're still primarily a QI collaborative, but we do research as part of it, and we got everyone's informed consent. Improved Care Now has done that. Or you can say, look, the QI collaborative is a QI collaborative. When we want to do research, and we're not going to get IRB oversight of all these data elements we're collecting because the primary goal of collecting them is not research. And when we decide to do a research study, that might be a research study on already collected data, we're at that point going to go to an IRB and say this activity is research, and they're going to tell us, hopefully they're not going to tell us that we have to go back and get consent for all of the participants who submitted data, because then you'll want to shoot yourself. Hopefully they'll see it as observational research on already collected data, the way we see research on a claims database resource or something else, and let you do it under those HIPAA protections and without consent. But I think different collaboratives have done it different ways. I mean, in some ways, I could let Chris comment. PEDSnet is an example of we've kind of split the difference. We've had IRB oversight of PEDSnet as a whole, and then but project by project we decide if there's a research project, it gets IRB oversight. But we certainly haven't gotten informed consent for every one of our patients to have their data submitted, de-identified to the PEDSnet data repository. Okay, other questions? We're coming to the end here. And we know that because there's a slide that says summary. So that's always good news.
I just want to, I think I'm going to share, John, this has been a terrific discussion. I'll let you get to your summary, but I think there is, and we've got some of the readings listed, but there is a robust discussion on what we should do, not what we need to do, but what we should do with patients with regard to letting them know that we're a learning health system where we are going to use their data to improve care, and we're also going to repurpose their data for research. And maybe we should stop thinking about like a one and done consent process, but more of an engaged discussion. By engaged discussion, I mean a continuous campaign with our patient populations about how we use their data to improve care, both using research and improvement. Because from a patient's perspective, that's kind of not only our perspective, that's a really fuzzy distinction. So I think there's a growing interest in the PEDSnet patient community in seeing the institutions adopt a campaign that lets the patients know sort of during every encounter that their data are being used to improve care, both research purposes and improving clinical operations. I don't know of a institution that sort of embraced that, but I think that does move us into a higher level of maturation for our learning health system.
Yep, I totally agree. And what Don said earlier gets that. It was in a slightly different context, but we've got to be talking to our patients differently and informing our patients and making it an asset of our health system that we're using data in this way. I will tell you that conversation in PCORI and things like that is, and also in some of these, I've been to a couple of kind of ethics-based conferences about this. I think we get a little bit of one-sided view because the patient advocates, the parents, the patients who come out are all very pro sharing and advancing science and things like that. And sometimes we hear from the patients who are very concerned about sharing any of their data, who are worried that Amazon has their data and Google has their data and the federal government has their data and they don't want their data shared at all. And I'm not saying those views aren't represented, but those aren't the people who show up at the meetings. It's disproportionate. So I just think we're going to have to figure this out. I want to wind up. I've got a meeting to get to, and you guys all do too. And I've used all of the hour and a half because it's been so much fun. But just to say, the current definitions are not perfect for what we have to do, which is to make, we have to call balls and strikes project by project, and it causes difficulties. I think the fog is starting to clear as organizations are having to do this by themselves, but are starting to use the same criteria, and there's kind of it's kind of case law. Even though we thought we'd be helped along by the revision of the common rule, we weren't. But we're figuring it out ourselves, and I think people are using similar criteria. And I think for you all who are starting research careers, it's just about being responsible for the work you're doing, and facilitating the evolution within institutions, so we can get to a place where the rules of the road are clearer, and really promote the learning in health systems, because nothing else makes sense. Okay, Jeannie, we're done.
Great. Thank you so much, John. This is fantastic. And I guess just in closing, I think Wednesday we'll be seeing everyone again because we scheduled an ad hoc meeting for the Research in Progress seminar, and Erica and Stephanie are kind enough to volunteer to share a little bit about their projects, and Chris will kind of lead us in a discussion on the featured article. And so thanks everyone for your time. Thank you, John.
Thank you, guys. Bye-bye.
Bye-bye.